let's have a real conversation about mental illness, especially the rising prevalence. I think that's probably a good place to start. And you mentioned recognition as something that in your book that might be contributing to the rising mental illness, or what people think could be a cause of the rising mental illness. And you give a really good example. You said, now depression is diagnosed in the context of a stressful scenario, right? So something happens and, the next day or that same week, if someone is depressed or exhibiting the symptoms of depression, then they can be diagnosed with depression, right? Versus before, a traumatic event, a family member dies, there was some space given for a natural grieving process. Versus now, it's just like, if you're having those symptoms, then you must have depression.
Yes.
That's a really good example, I thought. What do you think of the current DSM diagnoses for depression and I think more broadly mental illness?
So, DSM is essentially a book with a lot of diagnostic labels and a lot of symptoms under each label. It makes no claim for the cause of those symptoms. And on the surface, DSM makes sense. It's part of our culture. It's part of, the medical field. Names like schizophrenia, bipolar disorder, alcoholism or alcohol use disorder, anorexia nervosa. Those are the labels in DSM. And most people know what those labels mean. And they assume that these are real, valid, clear biological and or psychological disorders that they've been around for decades or centuries. We must have evidence that they are real disorders and that we understand them and that we just are looking a little more for cures or the exact cause. The unfortunate reality and bubble to burst for a lot of people, if that's what you think, is that that's actually not true. All of the diagnoses in DSM are what I would call syndromes. They are clusters of signs and symptoms and nothing more. And the reality is we really don't know what causes any of them. The challenge, when I say those labels, alcoholism, anorexia nervosa, and schizophrenia, most people know, well, those are completely different things. And they have a good picture of the anorexic teenage girl. They have a good picture of the alcoholic getting drunk, passing out. And they have the picture of the schizophrenic person hallucinating. And so those words mean actually something very significant to them. The challenge with the DSM diagnostic labels, though, come into not just this lack of validity, but two other things, heterogeneity and comorbidity. And what it means is that if you get diagnosed with a mental disorder, there's a really good chance you've got more than one. You're not just schizophrenic. You've got schizophrenia and OCD and an anxiety disorder and a substance use disorder. You don't just have anorexia nervosa. You've also got OCD and a substance use disorder and an anxiety disorder. And so now I've just mentioned two people, one with schizophrenia, one with anorexia, but they've got the exact same other three diagnoses. Yeah. And are they really different disorders when there begins to be so much overlap in the symptoms?
Yeah. I do wonder also, it seems like the cutoff line for mental illness, I mean, listen, I'm not a psychiatrist, so you probably know way better than I do, but it seems like also the cutoff line for mental illness is pretty subjective, right? Where is it affecting your relationships? Is it affecting your life? So on and so forth. So certainly there's a gray area there, right? And you mentioned this in your book, and I personally think there might be an element of this in our society today, but diseaseifying the human condition, especially from a mental illness standpoint where these symptoms, like you said, are very subjective. What do you think? Do you think that's going on today?
Oh, there's no doubt it's going on. And, so I'll come back to the example you brought up before, which is depression versus grief. And are they really different? So if I describe to you a man who has a wife and 2 young kids, and he is madly in love with this wife and 2 kids, he is the happiest man in the world. He truly loves these people. They go out grocery shopping on a stormy day and are hit by a drunk driver, and all 3 of them are killed. That man is going to become depressed. He might even start to consider suicide. He might start thinking, if he's a religious man, he might start thinking about joining his wife and kids in heaven. He might start to feel that his life has no purpose. I would argue those are all normal and expected human reactions. I'm not encouraging it. I'm not saying it's good. I'm not saying that he has to feel that way. But it shouldn't be a shock to anybody if he starts feeling that way. And if he doesn't feel at least severely depressed, everybody's going to think there is something wrong with him. He has a mental illness because he's not depressed.
Right.
Like, how could you not be depressed if you were madly in love with your wife and 2 kids and they get killed in a tragic auto accident? Well, according to DSM-5-TR, that man has precisely 13 days to get over his grief.
Before he gets assigned a diagnosis of depression.
And if on day 14, he still has clinical symptoms of depression, which I would argue, of course he should, he gets diagnosed with a brain disorder called major depressive disorder. Now, I'm not at all suggesting that this man doesn't need help. I'm not at all suggesting he doesn't deserve help. If that help comes in the form of psychotherapy, great. If that help comes in the form of a pill, great. But what I am very clearly saying is that man does not have a brain disorder. It just fails the common sense test to me that somebody would argue that he's got a brain disorder, and yet that is the state of affairs in American psychiatry, is that because he meets criteria for what we call a brain disorder, clinicians will think he's got a serotonin imbalance now, and therefore it's causing a brain disorder without regard to his life or common sense circumstances, and they will start medicating him. And some clinicians, unfortunately, good clinicians won't. Good clinicians might offer him medicine to try to take the edge off. Maybe sleeping pills, maybe antidepressants, maybe anxiolytics. Good clinicians will do something in the hopes of just alleviating his suffering, but they will recognize the primary problem is bereavement or grief. But some clinicians won't. Some clinicians will cling to DSM and will say this man has a brain disorder and we need to try pill after pill to get his depression to go away.
So let's look at the flip side. What do you think of the argument that, well, something like this is so traumatic that certainly this man is going to, or he's at high risk for persistent depressive symptoms, and eventually he would meet the diagnosis for major depressive disorder. Early treatment for an individual like this would benefit him in the long run.
I don't disagree with that argument. I don't disagree with the argument that early treatment might prevent a downward spiral. I actually describe a case like this in the book of a man going through a divorce who is spiraling down for 3 months and then gets relief from an antidepressant and a sleeping pill and psychotherapy. And I'm all for that, if that works. When you look at the statistics, though, In primary care practices, which is where most antidepressants are prescribed, if a primary care doctor starts you on an antidepressant, 5 years later, there's a 95% chance that you are still going to be on that antidepressant. We are diagnosing people with permanent brain disorders based on normal, common sense human suffering. There seems to be no attempt to get people off meds, but getting people off meds is difficult. These meds do have powerful effects on the brain, so you can't just stop them cold turkey. But most clinicians aren't even trained in how to get people off these medications. They don't make it a goal to get people off these medications because they rest on this assumption that this man has a brain disorder. He's got a permanent brain disorder called major depressive disorder, and he's got a chemical imbalance going on in his head, so he's going to need this medication for life.
Let me just say I agree with you 100%. But let's look at it from a physician's perspective, or let's just look at the whole scenario. Someone comes in, depressive symptoms, primary care doctor, they're supposed to know everything. They get put on a... What's so funny?
They're supposed to know everything?
Yeah. I mean, you know what I mean, right? It's a primary care physician. You're the first line in terms of...
I get it. No, I was just
the
poor primary care docs, the pressure on them.
Yeah. And we need more of them. But... all right, so comes in, depressive symptoms, SSRI, patient feels better after a month on follow-up. The patient's feeling better. He doesn't want to come off the medication. He's feeling better, right? The physician, right? He relieved this person's symptoms. So I could certainly see 5 years down the road how this patient could just continue on the medication.
Yes.
Right?
He could. So the reality is, let me do a reality check, though, of that situation that you just described. That is a rare situation. I see somebody with severe depression. I prescribe an SSRI. They come in a month later, and they are all set. That is very rare. 30% of patients in that situation over the course of 12 weeks, not just 1 month, over the course of 3 months, only 30% will get remission of illness. So what's more likely to happen is this man gets prescribed an SSRI. He comes back a month later. He says, "Doc, I'm not really sure if this medicine's working or not. I still can't sleep. I'm anxious as hell. I really kind of want to be dead. I miss my wife and kids so much." He starts sobbing and crying. The primary care doc's like, "Oh, I don't need this in my office right now. This guy's crying and he lost his wife and kids. Here's another pill. Let's try this. Let's add this. Let's do more." And the reality is, a year later, this guy's probably going to be on 3 or 4 different medicines. He's still not going to be 100% better. He might be better enough, but he still might meet criteria for major depression. And if he doesn't meet criteria, he may still have some lingering symptoms. And then we'll start saying he's got chronic treatment-resistant major depressive disorder, confirming our belief that he has a brain disorder. And now we are going to try pill after pill. And I'm not trying to be so pessimistic. I've been a clinician for 28 years now. So his symptoms will go into remission for 2 or 3 months. Or they'll get significantly better for 2 or 3 months, or 6 months, or maybe even a year if he's lucky. But then something in life will happen. He'll come back. Symptoms are coming back. He's not doing so great anymore. He's slowly but surely gaining some weight, slowing down. And everybody just assumes, well, that's just the way it is. And